today. My name is David Astley. I'm the chair of the trust, and I've been in post now for the last 3 years. Today you'll have the opportunity to hear from colleagues on our response to the pandemic, and we'll take a look back on our performance and achievements over the last year. We'll also talk about the areas we still need to improve. This event will be recorded and shared more widely for those that could not make it to this live event. So today is very much a two-way conversation with our members. So towards the end of the presentations, we've allocated a good amount of time for a question and answer session with all of you that are prepared to ask a question. When we come to that section, you can signal you want to ask a question by clicking on the raise hand icon in the top right hand corner of your screens. Please click again to lower the hand once you've asked the question. The minutes of last year's annual members meeting were approved at the December 2020 council meeting and are available to view on our website for reference. Pandemic has been hard for everyone in different ways, but for CCAM staff, knowing that what we do makes a difference to those we serve keeps us all going and keeps us well motivated. So does the huge outpouring of support we've received from the public, some of which we received again this morning at the Council of Governors meeting, and for that we really do appreciate, and we thank you warmly for it. Although we've been working through a pandemic, we have continued to invest in our frontline service and new technology because that's what's going to help our patients the most. We'd like to play you a film from earlier this year which illustrates how investing in and using technology helps us to provide even better care to our patients, enabling them to quickly access specialist care and avoid delays. I hope you'll enjoy what you have to see.
Sorry, David, appears to be an issue in loading that. Do you want to move on to Philip for his presentation, and Liz and I will take a look at loading the video after that?
Yeah, before we do, can I just take the opportunity then, while we're loading the video as well, just to say a few words about the current situation. I think it's appropriate, now we have the annual members meeting today, and also many of our staff will be online as well. But I think it's really important that I take the opportunity as chair of the trust board to acknowledge and thank all of our staff, volunteers and chaplains for the work they've done in the last year, which has been dominated by the COVID pandemic. Everyone has been affected in different ways. Some are still becoming ill as the pandemic continues unabated. Some are still suffering the effects of long COVID and are suffering the long-term effects, and we do also send them our best wishes for a speedy recovery. Some sadly have been affected by COVID to the point where it's contributed to their sad passing, and to them, to their families, we obviously extend our condolences, but our continued support in what we know has been a very challenging time. So we honour their memory, and we also wish a very speedy recovery to those that are still suffering the ill effects. So I think it's important we say that at the start of the meeting. We live in unusual times, and that we've had a splendid response from our staff, volunteers and the whole CCAM team, and for that I can only just say once again thank you.
So good afternoon everybody, I'm Philip, I'm the Chief Executive, and I'm going to talk about the last year and then end with a very brief look at the year coming. I just thought I'd show this slide, which sort of puts the pandemic period into pretty much the first wave, the second wave and the third wave. So in the first wave, if you remember, we moved on the 23rd of March into lockdown, and so that meant that our demand dissipated, but we were also asked to do a huge variety of other things. For a start, almost all of our non-patient-facing staff or call centre staff were asked to go home and work from home. which up until that point we thought would never work, and yet everybody did it, and it has worked really much better than we could have hoped. If you remember, at the beginning of the pandemic, there was a huge wave of demand for 111, as everybody decided that they needed to know something about something, and 111 was the place to get it. And so our service was significantly under pressure. And then we started doing helpful things to help the community. So we started supporting community testing using swabbulances. We created jumbulances to transfer multiple COVID patients around. These were in the days when we started opening the Nightingale centres. London got into severe trouble, and so several services, including us, supported them by sending crews into London to deal with things. And then you'll all remember that in that first period we were planning for Brexit in October, and so that's a forgotten memory now. But we were planning for the worst case, because at that stage we still didn't have a deal, and so it was a no deal Brexit. And then we had all the issues about PPE. We recognised that that not everybody was suffering the same privations, and some of our staff and patients were more vulnerable, and so we had people who were being given different categories of clinically vulnerable status, and having to work. So it was a really it was the time when we were learning how we were going to run the business by watching Boris Johnson at 4 o'clock on the afternoon, and having to start doing that the next day. So we had a really quick pace of life, a quick pace of communication. We were briefing people every night at 4 o'clock, and expecting work to start on it later that night. So it was a vibrant time, and there was a huge amount of goodwill from everybody, public towards us, and the cheering of the NHS and clapping on one evening a week, and all of that sort of stuff. So then we move into to the second wave, which started in Kent. So the Alpha variant that is on that slide, that was formerly known as the Kent variant. And at this point, I want to reflect on something that David's already said, because just at the end of the Kent phase, when the disease was still rife in Kent and not so much elsewhere, we had a bit of a rash of losing staff to the disease. And I want to reflect that 18 members of our 18 colleagues of ours have died over the period that we're talking about. And that's incredibly sad. That's 18 families who are living without their loved ones, and they are a huge variety. There's CFRs, there's members of staff, there's call centre staff. It's not all COVID. Some of it is just long-term sickness, and on top of that, we've got 37 members of staff who had long COVID. The longest has had long COVID for 18 months now. So there's a real significant loss, but also a destabilisation effect of the disease over the long term, much more so than it feels at the moment. So we want to remember those days and those folk who were very sadly no longer with us or still suffering. We then started. We had the military in, we had the fire service in, and again that was learning lessons, making up policies in order to make things work. And then we started the rollout of the vaccination programme. Some of the happiest scenes that I think I've seen during the pandemic were in the vaccine tent. particularly when staff brought their family members in. Those who were giving the vaccines were telling me that it felt like one of those life-changing moments when you're giving someone something that they wanted so badly. That was a real highlight when we got everybody who could be vaccinated really quite quickly, and then closed that down. It was great to see some 3 members of our team with MBEs, but I'll come back to that. And we were doing some normal stuff as well in there. We started, it wasn't all about the pandemic in wave 2. And then that has increased as we got into wave 3. So, it's now about living with the pandemic. The demand increasing and waning during periods of hot weather. The end of a lot of things that we've got used to over the last year, so shielding for people. A lot of rules have been relaxed. Travel started again, but it's still feeling a bit odd. But this is now how we, I think, will continue, and that is living with the pandemic. Those of us who are in the service, still having to take a lot of precautions, wearing masks, keeping a distance when you're at work, and all of that sort of thing, in order not to spread the disease amongst ourselves. But with society looking a lot more normal than it has been for a while, and preparing for further waves. As most pandemics have about 5 waves, so we're probably at least 2 more to come. And Katie, if you could wind on to the next slide. Okay, leadership and our people. Three of us got MBEs after the first wave, and that was really good for the trust. It makes everybody feel better when someone gets an award. It didn't stop there. One of the presenters on today's slide, on today's show, Fiona, later got a Queen's Ambulance Service Medal, which is a really prestigious award. So congratulations to all of those guys. We have changed some of the roles. Joe Garcia left us. Emma stood up and took his place, and we're about to recruit, or we're about to get David Ruiz Salada, who will join us as the Director of Planning and Business Development later this month. So some changes there, also changes on the non-execs in the way of the world. In terms of the staff survey, we had a really it was an interesting year for staff survey, because you really didn't know what people were going to say. But I was really pleased that so many people took the trouble to actually have their say. And in the end, actually the themes were pretty much the same as they have been. So we just need to keep our eye on that and make sure that that we're not going. But I was really delighted that so many people got engaged. It's a good sign of engagement. I want to go. David thanked all our volunteers, and I've on this slide I've highlighted one of the many roles that our volunteers did during the crisis, and that was the welfare vehicles. But it was so much more than that. Every time we said we've got a problem, we need to get 50 tests to a lab in Oxfordshire. A volunteer would turn up and would get the tests and would drive them to Oxfordshire, and would come back and say, yes, they've all been delivered, and sign a piece of paper to say that it had all been done. And no matter what we asked, there just seemed to be our CFRs, our padres, our and other volunteers, and even our corporate staff who wanted to add more doing things. So every time there was an ask, there was a really good resultant response, but particularly from our volunteers. And we celebrated the 50th year of the paramedic profession, which started in Brighton 50 years ago. And the big piece of news that in the middle of a pandemic, we started a new service, which was the clinical assessment service for 111 down in Kent, which sounds like a small thing, but it meant connecting the public through 111 to hundreds of endpoints around the system, and it was a really complicated thing that was done in the middle of a pandemic, and I salute everybody who was involved in that. Moving to the next slide. This just gives a visual about numbers. So 999 when I joined was bigger than 111. By the end of this year, by the end of the last year, 111 was bigger than 999. This year, we are on target to do 1.6 million calls in 111. So that just shows the pace of the change in what healthcare is delivering, where more and more people are using 111 to do things that they otherwise would have used GPs or hospitals or walk-in centres or even 999 for. So that's a significant change that we've seen over this period. When you look at the time-based targets there for 999, that's actually an improvement on the year before. So 4 seconds for call answer on average was really good. It's slipped a bit since then, I have to admit, but to do that over a year was a major achievement for a trust, and giving our patients a much stronger, a much better service as a result. Moving on to the next slide, Katie. Not only were we looking at time-based targets, we're looking at quality-based targets. And you can see on these slides that despite the pandemic, our clinicians have kept their ability to provide a really strong clinical service. And they haven't become distracted by having to wear PPE or all the other many challenges that they had. They were focused on getting the delivery right. So where there are failings in those, they're normally small failings. And I'm going to move on. You'll get a report on finance anyway, so I won't concentrate on the finance numbers. Moving on to the next slide. Falmer, the new Make Ready Centre in Brighton, opened in November 2020, and it is the best centre that we've done. It's got most of the things that you would want from such a centre, and it's been lovingly and very thoughtfully personalised by the teams there, so that they're remembering their history, they're remembering their deeds in the past, and they're remembering each other by the use of visuals around the station. A real success, and we're going to move on with those sorts of models for both Banstead and for Medway. Then I talked about the vaccination programme already, so I won't go into that, but just to say that we are ready now to do the next set of vaccinations, which are booster vaccinations, which we stand ready to do from the 13th of this month. It may be later than that, because the government haven't decided whether there's going to be a booster vaccination just yet, but we'll do soon. And we also went to help the folk in London, and we also received some support ourselves. And then a very quick look on the final slide up to next year. So we've got some challenges, there's no question about that. We need to improve our performance. We need to get our operational folk back in a balanced thing where they can work sensibly, and a lot of that means a lot of support being given to a lot of people. We've got to make sure that we are vaccinated against the flu, because there wasn't a particularly big flu pandemic or a flu season last year, because everyone was was in lockdown. So it could be worse this year. So the flu vaccination really important this year. And then we need to, and we are starting to do some of the learning of lessons for the last couple of years, deciding on how much we go back to the old normal and how much of the new normal that we keep going. And then there's new things that are just around the horizon. The Paramedic Apprenticeship, a really good example of that, sponsored by the University of Cumbria, but done locally. It's changing the way in which the paramedic profession can train itself. We need to learn more about that, and we need to get better at making sure our workforce numbers match the demand much more precisely. That's the role of the new planning directorate, and we'll give them the help they need to get up and running in the coming months. I think I'm going to stop there, and I'm going to hand over to David Hammond. So I will stop.
Excellent. Thank you very much, Philip. Good afternoon, everybody. For those who don't know me, I am David Hammond. I'm the Chief Operating Officer and the Executive Director of Finance. I'm now going to attempt the technology as well, so please bear with me for a second. Try it a slightly different way. Could somebody just confirm they can see a slide deck and that it moves?
Yeah. It does move. It just needs to be enlarged, David. Just click the cup at the bottom.
How is that, Katie?
Perfect, spot on.
Brilliant. Thank you very much. Okay, so I'm going to give you a quick run through of the financial performance for the trust for last year. I would normally do this having laid the accounts before Parliament and having them approved. Due to the pandemic, we're not quite at that stage yet, so I will come on to that towards the end. But what you're seeing now are the fully audited reports on our financial performance, which will go to through Parliament in September at some point. We're just waiting for the final dates. So I'm going to set the scene, and I'm going to give you some headline financial numbers, and in doing it I will also try and relate it into more enjoyable and real life issues and things than just giving you a set of balance sheets and profit and loss accounts. But I do have to do this relatively formally, so please do bear with me. So as Philip said in his presentation, 2021, as we all know, was an unprecedented year. It was very much reflected in the way that NHS financing had to work, and I have to say, for a system that is quite regimented and so forth, the ability to move with the times was excellent, not just from CCAM but across the region and the national teams. And in preparing for this, I was just reflecting on some of the things that we did last year, and Philip's covered some of these, but things like laptops to all corporate staff, home working kits, the amount of PPE that went through the system, powered hoods, FFP3 masks, aprons that everybody had to wear, screens around desks, working out how to social distance within the estate, standing up a critical care service, and various other things, including, as Philip said, the small matter of an EU exit and launching a 111 CAS service in October 20 in the middle of a pandemic. So throughout all of those things, which took huge efforts across the trust, we did manage to maintain excellent financial stewardship and governance around the way that we funded these things. That was really important and was reflected in our good value for money reports from our auditors, and our internal auditors were able to give substantial assurance that we had managed the funds in the most appropriate way. So in terms of some financial headlines, we did report a deficit last year, but this deficit was as a result of an accounting, what they call an impairment, where the estate must be revalued to the property value at the point that you do the revaluation. It has to happen once every 5 years, and last year was the year that it had to happen. So whilst our underlying position was effectively a break even, a 0.1 million deficit. We did put through £6.6 million worth of price change impairments on the property, which therefore means that in the accounts we report a deficit of 6.7 million. Our plan for last year was actually, excluding the impairment, our plan for last year was actually 6.4 million. But as a result of the way that the funding flowed through the COVID pandemic and some central non-recurrent funding and the fact that we managed our resources very well, our underlying position was, as I say, the 0.1 break-even deficit. The cash balance at the end of the year was 40.2 million, partly due to reserves that had been built up in order to invest in the trust in things like vehicles and estates, and partly because up until the end of last year we were given advance funding to make sure the cash was actually with providers and not sitting in the centre. So that was something that was well received by all people who were at the front end of the pandemic. We also managed last year to deliver about £5 million worth of cost improvements. These were not taken from the frontline resource or in any way, as you can tell by the investments we made in those areas, but also but rather from efficiencies and rebadging of contracts and making sure that we're getting the best value from the contracts that we had. We also obviously have an element of a non-recurrent cost improvement where certain services and items weren't delivered during the pandemic because of the lockdown, etc., and therefore we didn't incur the expenditure. And finally, and in some ways most importantly, we made nearly £20 million worth of capital investments in the year. I'll come on to that a bit later as to what we spent the money on. But in investing in the infrastructure and the tools that we give to our staff to enable them to do the job most as best that they can, it allows the best patient care to be given. Okay, so just some numbers, and I will run through these because I think they illustrate what I've already said. So you can see on the left-hand graph, our income for the year was nearly 300 million against 250 million the year before. There was a couple of main factors to that. One was bringing on new services such as 111 CAS, and also the non-recurrent central funding to cover the costs of the COVID pandemic. The waterfall chart on the right-hand side of this graph just really shows how the finances flowed. Our EBITDA is the earnings before depreciation and amortization in our case, and that's our true sort of operating position. We can see that whilst we had additional income, having a lower EBITDA than the previous year means that we also had additional costs, which I'll come on to in a second. So where does the money come from? So this is always an important slide, I think, that's good to know for the annual members meeting. So 73% of our income is from our 999 service, as you'd expect. 6% comes from 111, and that figure will go up as we build on that service and more activity goes through it, as Philip touched on in his presentation. We had 7% of our income last year from related to COVID as non-recurrent funding, and 5% from the centre for items which weren't directly badged as COVID but helped with the COVID response. And that goes back to the previous slide where you could see the growth in our income to some degree. Other income is just a mop-up of everything else, and then we have our hazardous response team in Ashford and Gatwick who receive central funding each year, which accounts for 3% of our income, and then various other education and ICS monies which come in make up that total of 299 million. How we spent the money this year, as always, the majority of our costs, our expenditure is on pay, as we'd expect in a staff-led organisation. We spent 6% on our fleet and 6% on our estates and infrastructure. We spend about 5% of our income on purchasing healthcare from other bodies, such as IC24, who are our subcontractor in our 111 service, and our private ambulance providers who supplement our frontline response in operations. The other areas are as would be expected, so we have some clinical supplies, we have some accounting adjustments and so forth, the provisions, and then we have a bit of training and so on and so forth. This slide here reports our financial position. This, in the old terminologies, would have been your balance sheet. What it really says is the underlying health of your organisation in terms of your asset base. So you can see we've continued to invest in our fixed assets, which are our buildings, our vehicles, our IT systems, etc. Our current assets are our cash and the people who owe us money, and you can see that that is stronger than the year before. But as I say, some of that is due to the way that the funding flowed over the year end. But additionally, as we had more costs to go along with our income, we have more liabilities, which are the people that we owe money to. So you can see how they balance off, but a positive position in that our assets are higher than our liabilities, which is where we want to be to continue to show that the organisation is healthy from a sustainability point of view in the longer term. And then finally, I just wanted to point out some of the things that we managed to do last year in amongst the pandemic, and on top of some of the things that I started the presentation with around the immediate actions that we had to do. So we spent £5.3 million of our capital in infrastructure in IT, in the control rooms, in 111, in our support functions, and making sure that we are as resilient as we can be for things like cyber attack and in cyber security. We spent £500,000 on medical equipment. We spent £10.3 million on improving the estates, and as Philip touched on, we opened Brighton or Falmouth Make Ready. We also started the work on Medway and Banstead, and we completed the work on Sheppey over there in East Kent, which was a massive refurbishment of the site. We replaced medical equipment last year in terms of defibrillators, and we also added additional equipment onto 25 newly leased vehicles. And I haven't included the vehicles on here because they're funded in a slightly different way, but from that you can infer we also leased an extra 25 new vehicles. So hopefully that is it's a bit of a whistle stop, but hopefully that gives you an idea of our financial position for last year. I think the headlines are we did a very good job as an organisation in responding to the pandemic, and we made sure that we kept our stewardship over the funds and the way that we're funded in line with the excellent job that we did elsewhere. I think it's fair to say that the conversations that we'll be having around this area next year will not be quite as positive in terms of some of the numbers as we've gone through this year's worth of the pandemic, and certainly there's a lot of conversation and pressure around NHS finances, as many of you will know from just looking at the media as we go forward. So it will be very much a watch this space, but we'll continue to work with our partners and ICS colleagues and our national finance teams to make sure that CCAM is in the best place possible. So it gives me great pleasure to ask the Council of Governors and the members to receive the annual report for this year. And as I said earlier, due to the changes around COVID, we haven't yet laid this formally before Parliament, and that will happen later in the month. But the report is available on the website and will be updated as soon as it has been laid before Parliament. So thank you very much for listening to me, and I will hand across to Nikki as our lead governor.
Thank you. Good afternoon. My name is Nikki Pointer, and I am the Public Governor for Lower East CCAM. So I represent the interests of people of East Sussex, Brighton and Hove, which is CCAM's Lower East constituency on the Council of Governors. This report will focus on how the Council, which is a group of 24 volunteers, including members of the public, staff and people from key partner organisations, have fulfilled its statutory duties in the past year. Our collective duties as a council are twofold: to represent the interests of our Foundation Trust members and the wider public, and to hold the non-executive directors to account for the performance of the board. We also have some very specific powers, and I'll outline where we have used those during this year. But first, I should start by reflecting on this extraordinary year. COVID-19 has impacted so heavily on most people in some way, and of course the ambulance service has been quite literally on the front line, providing care throughout the year. As governors, we have tried to support the service as it's acted to flex as is needed to keep providing the best possible service to patients while balancing the safety of CCAM staff and volunteers. I'd like to thank everyone working at CCAM for their incredible efforts to date. At the time of writing this, which was April 2021, lockdown restrictions are beginning to be eased and patient demand is returning to usual levels. We all hope there is no return to the transmission rates, hospitalisations, sickness and mortality rates seen during the past year. CCAM has sadly lost a number of staff members to the virus, as outlined elsewhere in this report. Council has been focused throughout the year on helping to ensure that the Trust was doing its best to protect its staff and volunteers, while recognising that at times the demand for its services was incredibly high, and the number of COVID patients meant it was inevitable that crews would find themselves at the sharp end of the virus. The challenges with PPE early in the pandemic were all well documented, but as availability improved, PPE has become part of day-to-day life for our crews. The hard work and stress levels of the crews and call centre staff during the height of the various waves cannot be underestimated. Many of our community first responders, including some governors who volunteer in that role, were unable to respond to patients due to lack of safety equipment, and so took to the road when lockdown rules allowed, to provide welfare support to the frontline staff instead. This was particularly valuable when hospitals were at their busiest during the first and second waves, and crews and patients were spending a period of time waiting to hand patients over to emergency departments. The welfare vans provided much needed refreshments and a friendly, if masked, face during long shifts. Council adds its thanks to all the incredible volunteers who have continued to support the Trust. The Trust has been a grateful recipient of charitable funding, which has helped stock the welfare vans, but also provided some cheer on our stations for our hard-working back office teams, from coffee machines and water bottles to a table tennis table. The funds have been put to good use for the benefit of our staff. If you have donated to NHS Charities Together during the year, we thank you. A notable success this year has been the Trust's extensive vaccination programme, which was able to extend to volunteers, including governors. One priority frontline staff were vaccinated. As I write, the Trust has started to roll out second jabs to eligible staff and volunteers. The way the Council has worked alongside the board during the pandemic has necessity moved online, with Council meetings and committees continuing virtually. This has had some benefits, enabling more members of the public and staff to join the meetings, but I think it's fair to say that governors have missed the contact with the board, and particularly the informal catch-ups that are possible when meeting face-to-face. Governors have continued to observe board meetings and board committees, which have also moved online, and have provided Council with assurance that board scrutiny and oversight has continued despite its many challenges. At the time of writing, discussions are ongoing about how we maximise the benefits of enabling online access to the future meetings while planning full meeting face-to-face when it's possible to do safely. Naturally, Foundation Trust members, membership engagement and recruitment, external events had to be stopped during the year, though we have held several sessions online to try and reach out to members with limited success. Communication via our membership newsletter, Your Call, has continued, and our membership numbers remain strong despite governors' lack of physical presence out and about around the South East. Our annual members meeting online was a huge success, with good feedback from more than 200 attendees who joined us in September to hear about the Trust's pandemic response and other areas of work. It is fair to say that for Council, as well as the board and Trust more widely, the focus has, of necessity, been squarely on responding effectively to the unprecedented challenges posed by the virus. However, Council have continued to seek improvements in other areas of the Trust where reasonable during the year. We do this through questions submitted between formal meetings, as well as holding the non-executive directors to account at our Council meetings. The areas of focus for our Council have included use of patient experience feedback and learning, improved staff engagement and communication, the Trust's evolving strategy and the impact of ongoing changes in the wider health system, and staff wellbeing. Council has a rolling agenda of scrutiny items covering the remits of each of the board committees, and these have continued throughout the year. Governor questions to the non-executives between meetings have included the following topics, some COVID related but not all. Assurance around plans to create a new make-ready centre in Medway, clarity around staff annual leave entitlements, concern at delays at some Kent hospitals, progress on project to improve response to falls, PPE provision and fit testing, monitoring of contracted ambulance providers, including around PPE, arrangements for staff to work from home, funding for the Trust Paramedic Practitioner Programme, streamlining the process for CFRs to access funds that they have raised, traffic management in Kent and the run-up to the EU exit, accessibility of service to hearing impaired patients, environmental considerations at new buildings, and improvements to the Trust provision of clinical education. In terms of our statutory powers, the Council has made several non-executive director appointments and reappointments this year. NED remuneration has remained static. The Chair, David Astley, was reappointed for a second 3-year term of office at our meeting in early March 2021. Lucy Bloom was reappointed for a final year in August 2020, and Laurie McMahon appointed for a second 3-year term from February 2021. Council appointed 2 new NEDs during the year. Professor Tom Quinn joined the Trust in October 2020, and Subhoshan Muganath in March 2021, both recruited by the Nominations Committee of the Council, working in tandem with Bain Recruitment Agency. In January, Council said that a fond farewell to Al Rayner, who concluded his second 3-year term as a NED at CCAM on behalf of the Council. I would like to thank him for his diligent service and wish him well for the future. Council were very sad at the passing of our non-executive director, Tricia McGregor, in June 2020. Tricia had developed a good relationship with the Council, and her patient focus was hugely appreciated. She is very missed. No council elections were held this year, but we have seen a few changes among governors. 3 governors stepping down for various personal reasons include Pauline Flores-Moore in May 2020 after a little over a year with us, Malcolm McGregor in December 2020 after 18 months as a staff governor, and Marguerite Beard-Gold in October 2020 after more than 6 years' service. Marguerite had been particularly consistent in her contribution to the Nominations Committee. I thank them all on behalf of the Council, and I am only sorry we couldn't meet up with them in person. Subsequently, we welcomed Colin Hall back to the Council, representing Kent and Medway, Upper East Seacam, Harvey Nash representing West Sussex, Lower West, and Nigel Wilmot-Coles as a staff governor in his operational capacity. Finally, as we begin to emerge from what we hope is the worst of the impacts of the pandemic, I must express again on behalf of my governor colleagues our admiration and deep respect for anyone working for or with CCAM and across our wider health and social care system during the past year. Governors must continue to hold the non-executive directors to account for the performance of the board in the interests of our members and wider public, particularly during times of additional pressure and stress. We do this with the utmost respect for the pressures everyone has been under, and we look forward to working together and meeting each other in the coming year when safety allows. Thank you for listening, and I will now pass over to David Astley, our chair, who is going to chair the Q&A session.
Thank you very much indeed, Nikki. I understand the video is now available for presentation, so can I suggest we give it one last attempt to show a short video, and then we'll give our chance for the people on the panel to prepare. But so, Liz, do you think we can see with the video?
I will do my best.
Real shock to me, to be perfect. It's never going to happen to me, but it did happen to me. I had a friend staying with me for the weekend, but it was on the 9th of February when we'd had very, very bad snow and ice, and the road was like a skating rink, and we never get our road sorted, and there was no way that I could think about getting the car out. Phoned for a taxi, he did. There was an hour-and-a-half wait. We left here, went up and waited outside of the Bradstow Mill. While we were standing there, I can't explain the feeling that came over me, and I just felt I was going to go down, and I just said to him, "Can I hold on to you, please?" I said, "I feel like I'm going to pass out." With that, there was a lady on the other side of the road walking along, and she called across. She said, "Are you okay?" I went, "Yes, I'm fine, thank you." By this time, my speech had gone, and I felt my face was funny, And she came across, she said, "No, you're not." And she turned to my friend and said, "Phone for an ambulance." I went, "I don't want an ambulance." She said, "You do, you're having one."
When we arrived, there was a fire responder there, and she was waiting outside with him. We got her into the ambulance, did all observations, found that her blood pressure wasn't too high, which we were quite surprised with. But between me and my colleague, we decided to contact the stroke consultant via FaceTime on our iPads at Kent and Canterbury Hospital. We discussed with the consultant our concerns, and the consultant was able to see the patient, and he decided that actually he would like to see the patient at Kent and Canterbury to see if she's having a stroke.
So this is a project that started a couple of years ago in partnership with East Kent Hospitals and Dr. David Hargroves, who's a stroke consultant and one of the national leads for stroke. And he suggested that we work to try and get telemedicine into the back of an ambulance so that when we go to a patient we think maybe having a stroke, we can have a direct conversation with a doctor in a hospital to see whether that patient really may be having a stroke, or whether they perhaps might be having what we call a stroke mimic, which means that they may be better off going to a local hospital or getting a referral to their GP.
It means that we can be making sure that patients are in the right place quickly, but also making sure that when they get here, we're ready for them. We can be literally standing by the door with everything ready to go, so that when they come in, we can assess them and treat them quickly. And that's essential when it comes to stroke, because every minute that somebody has a stroke, they're losing millions of neurons. So being able to get to them quickly, make sure they have the appropriate treatment quickly, saves lives and prevents disability.
As I got to Canterbury Hospital, they were waiting for me, cannula straight in my arm, and after that it was, you know, I had to lay for 24 hours because I wasn't allowed to move, had CT scan, they came and took blood from me and everything.
So not everybody that we go out to that's having a stroke is fast test positive. They can have other symptoms, like they may not be able to walk properly, or maybe just dizzy or confused and not be able to get proper sentences out. And to be able to liaise with a stroke consultant face to face, it's good to learn from the experience. It would be lovely if we could get more feedback so we could find out and carry on learning, because some of the symptoms that we do take in are very obscure and we don't come across it very often.
So what we're hoping is that we can roll this out to any other hospital in the whole of the CCAM area that's interested in it, and there has been quite a lot of interest in it from Sussex and from Surrey, and I've been asked to do a presentation for both of those areas on our findings so far, which have been very, very positive. So what we found is that about 50% of our patients who are fast positive actually don't need to go to the stroke hospital. So some of those will go to their local ED, some of them will be referred to their GP, and some of those will be referred to the TIA clinic. And we found no adverse incidents at all so far. We are keeping records of everything, and the UCL is doing a review of the entire project. So it will be looked at in detail to make sure that it's a safe way of proceeding. So once we've got those results, really the sky's the limit. I mean, we can use this for lots of other time critical incidents, such as maternity, such as paediatrics, anywhere really where we want to get the patient to the hospital that is the best for them and for their outcome. And more now what's happening is that hospitals are getting more specialised, and we can't actually, there are less incidents where we can just take the patient to the nearest ED. So what that means is that we have to make smart decisions about where to take those patients, and it's not always possible for our staff to do that with our knowledge and skills. And so it's fantastic to be able to bring the doctor into the back of the ambulance virtually to make those sort of triage decisions, so that we can take the patient to the right place, get them the best outcome possible. It saves us having to do inter-hospital transfers later, because we've taken them to maybe a less suitable place first of all. It also saves some patient journeys altogether if they can be referred to their GP. and it's just a really efficient way of triaging patients.
Yeah, I think it's so good to be able to know that you're giving advice very, very quickly, very soon after somebody's presented, when we know we've got this massive time constraint and imperative to treat and assess people quickly, and seeing somebody be whisked into exactly the right place, get exactly the right treatment almost straight away, and in good cases like Margaret's, benefit from it hugely and be able to leave hospital very quickly is just fantastic. It's really good.
If it wasn't for the fact of the speed of the ambulance crew and the modern technology, I would not be able, in this condition today. I have made a full recovery with many thanks to the NHS and the speed and the modern technology.
Thank you. That's a very moving story, but and with all of these annual meetings, it's good to personalise it to an individual patient's experience, because that's why everybody signed up to work for CCAM and the NHS is to help patients, and it's good that we have that evidence. So if we now move on to the final part, a very important part of today's meeting, with a question and answer session, and all attendees can signal they want to ask a question by clicking on the raise hand icon at the top right of the screen. Once you've asked your question and you've had an answer, please click again to lower your hand once we've concluded once you've had an answer. To try and get through as many as possible, we'd be grateful for succinct questions and answers, and succinct answers from the panel as well. Please don't be shy. This is your opportunity to ask the Trust a question. I'll allow some time for hands to hopefully go up while the panel introduce themselves to you. And I shall ask each of the panel in turn to make themselves known to you, starting with Philip.
Hi, I'm Philip Ansell. I'm the Chief Executive.
Nikki.
Hi, I'm Nikki Pointer and I am Public Governor and Lead Governor.
Fiona Moore.
Good afternoon, everyone. I'm Fiona Moore. I'm Medical Director.
Emma.
Good afternoon. I'm Emma Williams. I'm Exec Director of Ops.
Michael.
Good afternoon. I'm Michael Whitehouse. I'm a Senior Non-Executive on the Trust Board.
And finally, David.
Afternoon, everybody. I'm David Hammond. I'm the Chief Operating Officer.
So I'm just seeing if there's any question. I think we've got first, I think Michael Miller. Who's it? You were first with your hand up, Michael.
Michael, I've allowed your mic and camera, so you should have a pop-up. If anyone has any questions that they want to put, drop it in the chat function. That might be a bit smoother. But you should be able to come on screen, Michael.
Yeah, you see Michael's hand raised, but his microphone is muted. He can't. I think Michael's having difficulty unmuting. So I can come back to Michael in a moment. Are there any other? There must be some other questions. Let's throw it open to more widely. Tim Williams, can you come in?
I think people are going to need to drop their questions in the chat function for now.
That's in the show conversation icon. That's the second one. Second one in.
Okay, we've got some questions that are coming in.
Yeah, it's one there from Lynn at Medway Foundation Trust.
And there's Tim Williams, who we were just trying to go to before, who's asking what do make ready centres
What do make ready centres do? There's a question from Tim Williams. So Emma, I think that's a good starter for 10 for you.
Thank you very much. So fundamentally, a Make Ready Centre started off as being very much field operations based. It was a place that staff could come at the beginning of their shift, pick up a vehicle, and then go and work out and about in the community during the day. It's also a place where our Make Ready services that's currently run by Churchill are located. So that's a team of people who are responsible for cleaning, refueling and restocking the vehicle at the end of every shift to make sure that it's fully prepared each time it goes out. It also provides an administrative hub, so it's where our local managers are based, so that when staff need additional support or they have any questions or queries, it's a focal point for that as well. Most of the Make Ready centres are also designed to have facilities such as additional training space, so that if clinical skills need to be practiced or there's additional study to do, whether it be sort of a key skills or an ongoing programme or something a bit more bespoke, there's space and capacity for that as well. So it's a multifunctional, pretty big building. If you can think of, most of them look like they're off industrial estates, but they've been very much furbished to facilitate the work around keeping the business of an ambulance service going. They're set up very carefully to make sure that there's best flow for people and vehicles. And I think it's fair to say that we've learned a lot in the evolution from the early days where we had Paddockwood and Polegate through to Tangmere, through to Falmer, which is the most recent one down in Brighton. And we've actually had visits recently from both London and the South West Ambulance Service to come and see how we've done it, because they're beginning to move into their programme of making their own Make Ready functionality. So it will produce some additional efficiencies. It's a great facilities, big open spaces, and really conducive to good working. The thing that we're now taking on the fourth evolution is that within Banstead there's going to be an additional floor that's going to be a multi-purpose floor, but at Medway there will be 2 additional floors on the Make Ready Centre. So Make Ready Centres are usually a ground floor and a first floor, and Medway will have a second and third floor, which is where we will host our 111 and our Emergency Operations Centre for the East as well. So it's really becoming much more of a multidisciplinary location where we will be running both call centre functionality, clinical advice functionality, and then a field operations base as well. So they're very much at the core of our local geographical delivery units. Hope that answers the question.
Thank you, Emma, very clear. And we've got some great questions now coming through in the chat column. I think the next question, Fiona, are you able to see Lynn Gallimore's question? Is there any interest in showing?
Yes, thank you. So the Kent were the county, or the county in which the hospitals embraced the idea of telemedicine for stroke first, and that's what was being shown in the video. So the neurologists, the consultant neurologists and stroke physicians in Kent, particularly at the 3 stroke centres, very much embraced this, and that the pilot study that we did there showed that the telemedicine was extremely effective in triaging those patients who needed to be seen in an acute stroke centre, because not all patients who present with the positive face-arm speech test are actually having a stroke. As Claire Hall said in the video, there are a significant number of stroke mimics, and of the group of patients, which is over 200, about 40% were triaged straight to an acute stroke centre, 35% to their local hospital, and the remainder were able to be safely managed at home and followed up either by their primary care physician or in outpatients.
Thank you, Fiona. While you have the floor, there's a question from David Gregory of what do red epaulets represent? You proudly wear yours on your shoulders, but I think one of our other colleagues on the video was also wearing a red epaulet as well.
Yes, so the red epaulets are worn by specialist clinicians. So by, excuse me, our critical care paramedics, our paramedic practitioners, and the very small cohort of doctors who work directly for CCAM.
So essentially, these are clinical senior clinical response.
They are very special people, David.
Yeah. No, we duly know that. Thank you. Right, thank you. Now there's a detailed question from Michael Miller. I wonder whether David, you might be able to. This relates anything to IT, EPCR, our patient care record. Sorry for the jargon.
Yeah, thanks, David. I think this this question's quite a specialist question, which we'll probably need to take away and come back with a more detailed response on. In terms of EPCR, we're already, as many of the ambulance services using the Cleric EPCR on the iPad. So in terms of the data and the detail that sits behind it, and the subsets of clinical data and so forth, we'd need to give that, I think, to somebody who wears red epaulets, probably in Fiona's team, to come back with a more detailed answer on how that works. So if we could take that one away, David, and we'll work out with Katie how to share that back.
Yeah, I'm just for the information to people who are on call. I mean, Michael's question was relating to the developments as the new integrated care systems come online, and it's a reference to using a clinical classification called SNOMED CT subset as part of the sort of official clinical oncology data set. So it is a specialist question, but we will come back. The headline, though, is, as David has illustrated, is we are looking to increase our technological solutions to ensure we have connectivity with hospitals and other health partners, and that will be a feature of our work over the next few years, is to make sure we can connect. And the clues in the title with ICS, integrated care systems, and that's certainly what CCAM certainly intend to play their part in doing so. There's a question there from Isabel. Alan, if there was one thing you would want members of the public to understand about how to help the NHS with its current pressures, sorry, I just lost that question. Isabel, do you want to come and ask it yourself?
I've got that up, David. So if there's one thing you would want members of the public to understand about how to help the NHS with its current pressures, what would that be?
Tilly, do you want to first go at that?
Yeah, thank you, David. So I think it's a question of understanding your local environment, so that you understand what is around you in the NHS, and therefore, depending on when you need the NHS, where best to start. But what we don't want people to do is to hesitate about asking for help, because we're busy, we want sick people to ask for the right level of help. But it helps if you just are aware early on what is your local provision, and therefore you know whether it's going to be 111 999 or walking to your the walk-in centre, or driving to a UTC in the local town. Urgent treatment centre is UTC. So I think it's just understanding the local health provision.
Thank you. But I'm perhaps bringing Emma and Fiona for this, because I think this is an important question, because we are having demand outstripping supply currently. Emma, from the point of view of our crews and the people, the front line and in the EOCs, is there any particular message you'd want to get across on their behalf to the public about how to better access the NHS?
Thank you. Thank you, David. I think the reality is that 999 is always here. We are here 24/7. We are here for situations where people need immediate help, and we will absolutely triage everyone appropriately to get to you as quickly as possible. I think the reality is with the whole NHS as it is at the moment, undergoing significant pressure, we also all need to be responsible for our own health and our own well-being. So we need to look after ourselves and make sure, whether that be adhering to wearing masks when we're out and about. I know there's an awful lot of people now who are doing less of that. We need to be really cautious about all of this. And we need to be really mindful that the virus is still out there. So I ask everyone to number one, we all need to look after ourselves and our loved ones and those around us, not only for ourselves, but those that we intermingle with. And then there's many different access points for advice and guidance. Pharmacists have, over the last few years in particular, really expanded their scope at being able to provide advice around some minor health and illness issues, and provide really good, obviously, pharmacological support. 111 is there, but 111 is also online. There are many different apps and things you can get support. I know my GP service has linked up with one of those GP online services. So there's many different contact points that people can get support from. We will be here. We are always here. But I think it's right now it's about using the NHS as smartly as you can, and reaching out to places like walk-in centres, reaching out to urgent treatment centres, getting advice about where the best place to go is before you go, because right now, if you need the help, you need to get it, but you need to get it from the best place possible, just to be as efficient for yourselves as much as all of us.
Fiona, you recently fronted an information campaign to the public as well. Is there anything you'd want to add?
I think I would absolutely emphasise what Emma said about we're not through COVID yet, and we need to be careful about interactions with people and maintaining infection prevention and control guidelines. I think it's really important that we try and avoid what we saw in the first wave of COVID, was that people tried so hard to protect the NHS that we saw a significant number of patients with heart attacks and strokes not calling us, or calling us very late. So if you have a real emergency, and I think most people are aware of what a real emergency requiring 999 is, then they should call us. But otherwise, they should think of using the 111 system online, because that gives a rapid response without putting additional pressure on our control rooms.
Thank you. We move on to a question from Robin Whitwell. Robin's saying, are any plans for increasing the numbers of CCAM crewed ambulances to assist with the increased demand, whilst allowing potential for staff decompression time after difficult incidents or series of incidents? I appreciate the pressure on crews, but was surprised recently that 2 ambulances were diverted, and then no ETA could be provided with when taken in at Gatwick. So Emma, are you able to deal with that?
Yes, of course. Thank you, David. Robin, I think it's really important just to recognise the challenge we're all under at the moment. Every day we do all we can to put as many crews out as possible, both on our double crewed ambulances and the range of single response vehicles that we have. We are really trying to support that by doing as much work in our control rooms as we can to support those patients where it's suitable over the phone, to provide telephone advice and guidance, so that we really try and optimize the number of calls that we go to physically, bearing in mind the resourcing levels we have. We are running significantly under our optimal staffing levels. It's not just us, it's a national ambulance position. We have regular catch-ups we all do with our counterparts in the other organisations. This is a national position we're all under at the moment. It's the summer, so we've had maximum annual leave. We've also had situations where people have been in lockdown for a long time. Having some time off is really important for everyone right now to do some of that decompression and that rest and relaxation with friends and family. We also are experiencing higher than normal sickness levels. Some of that is COVID. Some of that is not COVID, and it ranges from mental health issues such as stress and anxiety through to some other musculoskeletal issues and other problems. So these, in combination, these are all creating an environment where we are not able to put out the optimal number of hours we would like each day, whether it's for call takers, whether it's for paramedics on the road, or clinicians in 111. We are doing all we can to be as efficient as possible, to make that as effective as possible. We are also working with partners such as our private ambulance providers, who we subcontract a proportion of our work to get them to ramp up additional hours as well. Obviously, they're facing the same struggle we are with staff. So in answer to your question about increasing the numbers of CCAM crewed ambulances, please believe me, every minute of the day, that is our focus at the moment, to try and put as many hours out as we can. But there's a balance that we need to do that, because as much as we want to encourage people to taking up some overtime, for example, to support it, overtime is done on time that is people's time off, and they need that time off as well, because we have to we need to consider the welfare of our staff as well. So it's a really fine balance, and we do understand the implications of it every day. So when you say about the ambulances diverted, unfortunately that would have been because they would have been diverted for a higher acuity call that had come in within the area, and so we needed them to go to that first. So that's the situation we're in. It is very difficult, but we are doing all we can to really make improvements every day and do the best that we can.
Thank you, Emma. And I think the next question, while you catch your breath, Emma, there's a question from David Gregory. What's the difference between paramedics in urgent care and the paramedics in critical care? Fiona, could you take that, please?
Yes, of course. So both groups of paramedics are specialist paramedics. So they are both, they have both done a number of years post registration. The paramedic practitioners are specialised in urgent care, which means that they deal with patients with multiple comorbidities, and they also deal with things like wound care. So they have undertaken additional training with general practitioners and undertaken placements in primary care. They carry additional drugs such as analgesics and antibiotics, so they can often keep people with more minor illnesses who don't require hospitalisation at home. Our critical care paramedics deal with the most seriously ill and injured patients, so we task those to serious road traffic accidents, to patients in cardiac arrest, to patients with heart attacks, and patients with epilepsy that's not controlled by the first line drugs. Both groups of paramedics are trained up to and including a master's level qualification. So they are our most highly trained clinicians working across the spectrum of disease, from the really acute to the patients with multiple comorbidities.
Thank you. And in the question there from Roberts, I think we'll take a due note of that, Roberts, and we'll get back to you with a written response. But thank you for your inquiry. There's another question there coming, I think, from this is from Andrew Latham. When will the trust actually start the community falls team? Excuse me, the screen moves when more questions come in. It's difficult to follow. So when's the community falls team coming into place? Philip, this is a really important question we've been asked.
To be honest, I'm probably not best placed to answer that one. And Fiona, I think I'm coming to you.
Yes, certainly I can take that question. And Andrew, I completely understand your frustration on this. Essentially, and Emma will probably come in and have something to say about this as well, but our community resilience team have been pretty stretched, and although we've undertaken some training with the community fallers team, actually getting the system up and running, we're at the moment completing the governance, and I believe that the policies and procedures were signed off by our senior management group this week, so we should be able to take that forward. But I know that Emma's team have been quite constrained in terms of their resources.
Just if I can, just to jump in, absolutely. I think what's been useful as well is whilst we've been under particular levels of surge, where we have had areas that we've been able to do it, we've put some CFRs out with some of our OTLs on cars to go around and pick up some of the really long waits for the fallers. It's been a really fine balance about how we do it. But both Fiona, I'm with Fiona, we're committed to make this work. It's just been a case of timing and the capacity to do it in a way that is supported, that is overseen well, and that isn't just out there to allow people to get on with it, but it's a way that is really supported by local teams and the CFR management team as well.
But thank you, Andrew, for the question. It's something which is very much in the Trust Board's eye, and we are keen to see this develop, because it's one of the should make an impact on our Category 3 response times, but more importantly, help our patients in distress. So we are keen to really get this underway. I think Julian is making a further point. Emma, are you able to see in the?
Yeah. So and it's really difficult, because obviously we're reading text and I'm trying to respond to the text messages, and I can see Robin and Julian have commented on this. I think, perhaps I'm not completely understanding the question that you're asking, because you're talking about adding to the fleet, in inverted commas. I think the reality is, in order to add to the capacity that we have, it requires finding people to work on the vehicles, well, primarily people to work on the vehicles, because we've got the ambulances. They're sitting outside make readies at the moment. The challenge is I haven't got people to put on them. So as much as we are recruiting, we are doing all we can. There is no pot of paramedics or other appropriate people around that we can just put on these vehicles. So I think that was what I was trying to explain, that we are working with partners. We did some work with the fire service. We obviously had used the military earlier on in this year, but that turned out to be not a feasible option last month. So in real terms, the challenge we have is not about the vehicles. It's about having bodies to put in the vehicles, qualified, competent bodies to put in the vehicles with the right qualifications. But we are working with partners. We are working with St John to get some more of their volunteer crews in. So believe me, we are reaching out all over to see what we can do to support this. But it's, as I said, every ambulance service is in the same position at the moment. So we're all fishing from a pretty small barrel of additional support at the moment.
Thank you.
I hope that answers your questions.
If I may, Michael, as Senior Independent Director and as Deputy Chair, I mean, we're just saying just a little bit about the board's interest in the subject and how we're working towards making CCAM more sustainable, so we can give more support to our frontline crews.
Yes, certainly, David. Really want to emphasise everything that Emma and everybody else has said. We are really focusing on the moment at ensuring that we make the best use of the resources and people that we have got available to us, and that we support them as best as we can to ensure that their well-being is maintained. As a board, however, we do want to be strategic. We want to take a longer term view, so we create an organisation that has resilience and can continue to develop and deliver new services to CCAM's communities. So under David Hammond as Chief Operating Officer leadership, we have a project that is looking at everything that we do, taking a longer term view and thinking very carefully about how we organise ourselves to be resilient. And the board is very interested in this. There is a subgroup that is supporting David and also, in the old-fashioned term, holding him to account to deliver on this. So it is very much in our perspective, it is important that we take that longer term strategic view, we invest in CCAM and we continue to support our people.
Thank you. And perhaps the final question, which is appropriately, if I point in your direction, Nikki, do the Council of Governors feel that their work with the Trust is worthwhile? There you are, put you on the spot.
Yeah, thank you. Yes, absolutely. As a council, that we do provide a valuable and wealth of experience to the group, and we are able to hold the non-execs to account for the performance of the board. There's 24 of us, and we come from varying backgrounds. I personally work for the NHS myself. I'm a nurse, but we have a wealth of experience that comes. So yes, it's absolutely worthwhile. We do have a wonderful chair who makes sure that we all run on time and that we're all appropriately answering the questions and holding our NEDs to account. And we have a good support system in the back with Izzy and Katie. So it is absolutely worthwhile. And I would encourage anybody who wants to contribute to the strategy and vision of their trust to go for it and to come on board as a governor, which, funnily enough, elections are starting to run in September. So if you are a member, absolutely come on board.
There is a saying that bureaucratic sense must justify itself to common sense, and I think what I would say from the point of view of being the chair and on behalf of the non-exec directors, we have a wide variety of governors, many of whom are our staff, and you do need the sense check, and it's really important that people are grounded. We're here to serve the public, and just give them the best service we can within the available resources. We don't have unlimited resources, as we've heard today, so we've got to go forward with care, but nevertheless we do need to be questioned, and that I can assure you the Council of Governors do that, and I certainly feel held to account by Nikki and the rest of the governors. Thank you. I think at that point, as it's getting towards the time of closing the meeting, is there one more? Yes, Robin, you're on the ball today. Another question: has CCAM considered working with the leaders of other ambulance trusts in the development of a standardised grade not requiring a paramedic science degree? The training of tech or similar roles are a lot quicker and could include day release opportunities for upskilling to paramedic, as done in Surrey ambulance days. So this might be a combination of Philip and Emma, I think, in terms of answering this question. We'll make this the last question.
So I think the answer is that we have that, and it's called an AAP, an Advanced Ambulance Practitioner, which is the middle role. It's the old technician, as I understand it. But I think that's the simple step. It is quicker to do it, but it's not that quick. It takes over a year. We haven't got anything such as a roll up, do 4 or 5 weeks training, and you're a qualified clinician, such as there used to be in the Surrey ambulance days. But probably someone who's been in the ambulance sector longer than me ought to answer that. So Emma, maybe you.
Thank you, Philip. And it's a little bit of poignancy, because I am old enough that I started in London as a trainee technician some years ago, and I worked my way up to being a paramedic and clearly beyond. I think that the challenge is that we work with the HCPC, we work with universities and nationally, that the paramedic is the clinical standard for ambulance services in terms of a registered professional. In terms of those staff who work alongside them who are non-registered, we all have programs where you can train to be an ECSW, so an emergency care support worker, which is a much lower level of learning required to do that, to create a competent member of staff to work alongside a registered member of staff. And as Philip has described, there is a pathway for people who wish to go from an ECSW through the trainee ambulance, apprentice ambulance paramedic and upwards. At this point in time, I haven't personally had any conversations with any of my directors of ops anywhere else relating to considering starting a separate role that would be as you described, Robin, because I think at this point what we have is the ECSW is a well-defined role that is present in every ambulance service, albeit they're named slightly differently, and we very much our model is based on a registered and a non-registered, with the ECSW being the non-registered standard, rather than restructuring a technician kind of level role. So I hope that answers the question.
Well, I think to conclude, I think what we've heard today from colleagues regarding this matter, and in the meeting this morning with the Council of Governors, we do need to be flexible and come up with innovative solutions going forward, though, to ensure we get the best out of developing our future workforce. We're in a competitive labour workforce market, and we do need to ensure that we're being flexible. That being said, it's a wonderful career, and it's one of the few careers still where you can, as Emma's ably demonstrated, you can join us at junior level and work your way through to a very senior position. So if you're good enough and determined enough, you can get on, but it's we need to make sure that people are clear of the steps they can take to further their career. So at that point, can I conclude the question and answer session and bring the annual members meeting to a close with it? Let's say one thank you to the organisers of this meeting. And I think today's challenge indicated living in a virtual world has many advantages, but it also has many challenges. And the sooner we are back together in person on a regular basis, the more we can work collectively together on innovative joined up solutions. It is increasingly becoming more challenging working in a virtual world and understanding the needs of many thousands of staff and working collaboratively. So thank you again for your participation in the meetings. Thanks for your questions. I hope you feel that the board are being held to account, and CCAM is as well, and our annual report will be available in these coming weeks for you to look through in more detail. And also these proceedings will be available online again for those that wish to go into things in more detail. So thank you again. Have a good afternoon, and we'll see you in due course. Goodbye.